Good afternoon, everyone, dear colleagues. It is my pleasure to welcome everyone to the second day of online seminar series about addiction medicine for general practitioners. I am Dr. Evelyn Wijaya, a research assistant of Psychiatric Department of Atmajaya University. I will be the host for today's session. We'd like to extend a special welcome to our guest of honor, Prof. Dr. Arnt Schellekens, PhD, who will be speaking today. Dr. Eva Suryani, psychiatrist as a committee chairman of this seminar, and Atmajaya Collaboration, Radboud University Medical Center, and Nijmegen Institute of Scientist Practitioners of Addiction, who supports this event. We're so glad to have you all today to learn together about addiction medicine, which discuss specifically about evidence-based addiction. So today's agenda will be a guest lecture from Prof. Arnt and will be followed by discussion session. Okay, please, can you share the slide for the presentation, Mas Yosef? We'll be waiting. Okay. For the event information, okay, next. Okay, for today's agenda, the experts lecture will be presented in 60 minutes and will be followed by 45 minutes discussion. And participants could ask question by raising hand if you want to ask the question directly to Prof. Arnt, or write in the chat room. And participants could also see the online seminar through YouTube channel FKIKUAG. For how to get the e-certificates are only given to participants who have filled the registration and pre-test before each session, and also post-test with pass limit value 80. And it can be repeated if you haven't reached the pass limit value. The post-test link will be given at the end of this event. The link will be closed at midnight, 12 a.m. West Indonesian time on each day. Okay, before we enter the main agenda, let's have some poll questions. If you could see on your screen, sorry. Poll question for day 2. If you could see on your screen, please choose and click one answer to each question, and then we will see the result together. Okay, here's the results from our participants today. There are 50% who work in drug-related facility, and most of the participants get 1 to 10 patients in the past year, and only 30% of all the audience have ever done psychotherapy. Okay, next, I would like to invite Prof. Arnt as our guest speaker and Dr. Durotul Ikrimah as a moderator for today's session and lead the session. Dr. Durotul?
Yes, thank you, Dr. Evelyn. So, welcome everyone to this second day of online seminar of addiction medicine. We would like to invite our guest lecturer, Professor Dr. Arnt Schellekens, PhD. Welcome, Prof. Professor Arnt. Okay. I'm sorry, I would like to.
Yes. Good morning. For me, good afternoon for you all.
Yes, morning, Professor.
Yeah. So, I was not able to unmute, but now it's fine. So yeah,
Sorry.
it's
So I'm sorry, maybe for those of you who just joined this seminar starting from today, maybe I would like to introduce Professor Dr. Arnt Schellekens once again.
okay.
Yes, so Professor Dr. Arnt Schellekens, PhD, is a professor in psychiatry and addiction in Radboud University of Medical Center. He is also a scientific director in Nijmegen Institute for Scientists, Practitioners in Addiction, and also researchers from Dunder's Institute for Brain Cognition and Behavior. So Professor, yesterday lecture is really opened our eyes that maybe all the time we as general practitioners maybe had given a stigma for our patients and also for this disease. So your lecture is very insightful for us. And also we have learned from you that, from the science, from the symptom to the science. So now let's move on from the science to symptoms, from the bench to bedside. Now, today, we would like to hear from Professor Arnt about evidence-based addiction medicine. So in this lecture, we will like to hear about the therapeutical approach, a holistic therapy for our patients that maybe not only physical, but also psychological, social, and also environmental. Okay, for Prof. Arnt, you can share your slide. The time is yours.
Okay, wonderful. Thank you very much for the very, very kind introduction. Would you also be so kind to allow me to share my screen? Because otherwise you have to look at these three ugly faces the rest of the coming hour, which is maybe not what you prefer. I cannot share my screen, so...
Yes,
there we go. Yeah, now it is going to work. And so let's go. Yes, so, and I hope now you can see the slides, is that correct?
Yes, wonderful.
Good, wonderful. Yeah, so as you know, it's an exciting day today, and that is not at all about this lecture, but it's about other things that are going on in the world. So I can understand if you every now and then are a bit distracted by incoming news from the United States, which is far more exciting than a lecture from me. But still, I'll do my best to make you enjoy the coming roughly an hour or so, and also try to bring some new information to you if possible. I hope most of you were there yesterday and somehow enjoyed listening to the lecture. I also learned that people are interested in the slides, which is, of course, no problem at all. I will send them, share them with our organizing committee, and then probably they might be able to distribute to those who want to take a closer look at the slides. That's no problem. So, what I already explained to you yesterday is that Radboud University is in Kota Nijmegen, which is here in the southeastern part of the country. And we have a strong connection with the clinic, which is very important for the topic of today. That we have all these regional addiction care facilities where we can look for treatment improvement, look for treatment studies that we do. So I would like to share a bit about that today. Let's see whether we can move on. So yesterday we did from symptoms to neuroscience, understanding the behavior of patients with addictive disorders. And today I want to move back from the insights from the neuroscience to the treatment. Because I think if you understand what the pathophysiology of a condition, then obviously you might also understand better how to treat it. In most conditions, we want to understand the pathophysiology and from there develop the treatments. And I think for addiction, we are quite close to linking the treatments with the neurobiology. So I'll do my best today to give some insights there. And then tomorrow we will do another lecture, but focus on a specific condition, which is opiate use disorder in patients with chronic pain. So maybe a short summary of yesterday's lecture. So we went through the DSM criteria, showing that loss of control is the key element of addictive behavior. And we tried to understand the biology of this loss of control, the neurobiology of it. So basically we went through two domains, so the salience domain and the cognitive control domain. The salience network in the striatum, the cognitive control network in the frontal cortex brain areas, and how these two interact, as you also saw in the video with the kids with the marshmallow experiment. So this was the situation in a normal brain. We have all kinds of memories. We respond to stimuli in the environment that provide us with an approach response. And the control that is sort of coming from the salience network, this approach response, and the control network inhibits this approach response, so we can control ourselves. And in the addictive brain, this is quite different because all these drug-related stimuli are so salient for these people that the brain responds mainly to drug-related cues. So we saw this cue reactivity pictures in the brain, in the striatum activity after people were shown either videos or photos of drug-related cues. And the salience network takes over the control network. So the brain is directed towards a go for taking drugs. So some people say life is basically consists of two movements, and that's either approach or avoidance. There's nothing more than that. So, and the old psychoanalytics said, well, there is only two things, that's libido and aggression. And that's basically the same idea. So there's a quite fundamental thing in approach or avoidance. And you see that in very ancient animals that, these more primitive animals, that their brain mainly consists of an approach and an avoidance system. And of course, in our case, there is this prefrontal cortex area that lays over it, that guides our behavior a bit more subtly. But still, this approach and avoidance issue is sort of a basic part of human behavior. And I showed you this horse and rider model. So the horse is this drive for drugs, or you could also say, well, amygdala activity would also be the same thing, so anxiety. And then the rider sort of chooses the behavior based on the input of the horse, the power of the horse to approach or avoid. So what we said yesterday is that the rider is more located in the prefrontal cortex area and the horse is more located in the midbrain, where we focused pretty much on the ventral striatum, nucleus accumbens, the reward pathway. Of course, there are other brain areas in the midbrain that deal with emotions, like I just said, the amygdala, which more detects anxiety. And that is also a very strong drive, of course, to run away or whatsoever. And then again, the prefrontal cortex sort of directs whether to do that or not. So this is a very quick summary of yesterday's lecture. We said, well, this horse part of the brain, the midbrain here, ventral striatum, you see that there is a problem with patients with addictive behaviors. and that part of the brain contributes to anhedonia because the dopamine receptors are less available in the brains of people with an addiction, and this system does still respond to cues which elicits craving. So you have a nice pathophysiology. Well, nice is maybe not the correct word, but we have the idea that we quite well understand the pathophysiology of what we see in patients with an addiction: craving, cue reactivity, and anhedonia. And if we look at the control part, the control network of the brain, we see that the brains of people with an addiction have less activity in the prefrontal cortex. I also showed you that volume reductions in the prefrontal cortex are associated with the risk of relapse. This really relates to loss of control and continue of using despite negative consequences, because people cannot inhibit this drive to go for behavior. So that's basically a very simple sort of model for the pathophysiology of addictive behaviors. So I think short summary of yesterday, but it might be good to just recapture that a bit. So that is what we saw yesterday. These guys, these are different. One has loss of control, the other maybe thinks, well, I should not continue. And we have the idea that we understand a bit about maybe some brain differences between these two guys. So if we move to treatment, you could say, well, maybe we start from the same pathophysiology. We start from this reward circuit. There are less dopamine D2 receptors. So what kind of treatments tap into that pathophysiology? What kind of treatments, either medication or biological treatments or psychotherapies, tap into the reward system? And of course, I don't know what you already know about that. But we know that there are the most effective treatments for addictive disorders are motivational interviewing, contingency management, the community reinforcement approach. That's what CRA stands for. So we have MI, motivational interviewing, CM, contingency management, and CRA, which is community reinforcement approach. And I'll explain a bit more about that later on, but those are psychological treatments that try to sort of win back the reward system from the drugs towards more healthy behavior. So a healthy lifestyle without the drugs. And to support that movement, you can also give anti-craving medication. So we have for several substances, there are quite good anti-craving medications. I'll explain to you in a little bit more detail which are these medications and how do they work. And then also yesterday, I told you about substitution treatment with agonists. So like methadone for people with heroin dependence. And you can imagine that agonist treatment also taps into this reward circuit. I'll explain to you a little bit more about that later. And then finally, the past 5 to 10 years, there has been a new biological approach to both the reward pathway, but also the cognitive control pathway, using neuromodulation techniques. And that's still quite experimental. But maybe this will provide some good perspectives for new treatments that might be even more effective than what we have so far. And neuromodulation, then you should think of a way to change the biology without providing medication. But for example, using deep brain stimulation, so neurosurgery, and then if you tap into the striatum, you could imagine that you there try to activate the reward system electrically. So people do not have this anhedonia and do not have this strong urge after seeing cues, drug-related cues, because you can either stimulate or inhibit the brain using such electrodes. So this might be a way to go for the future, but brain surgery is really something. I mean, it's not an easy step to take, and people, undergoing brain surgery. Yeah, that's also like, people really have to be motivated for that, and give permission, of course, after really understanding all the explanations about the treatment, because a surgery is still a big step. So if we move to the prefrontal cortex areas, there is a little bit there related to neuromodulation. So you could think of transcranial magnetic stimulation, so using magnetic fields to induce activity in the prefrontal cortex. And by doing so, you could sort of train the prefrontal cortex to become more active. As we do for mood disorders, for example. And this is also still experimental. So also in our lab, we are currently testing this transcranial magnetic stimulation approach for the effectiveness in alcohol use disorder patients. So it's still experimental, but it might provide some new perspectives. In terms of medication, you could think of cognitive enhancers, but that's also still quite experimental. I think the most important treatment that targets on the prefrontal cortex currently is cognitive behavioral therapy. Okay, this is just a short overview. We'll go into more depth afterwards. I just wonder, is this clear enough? Are there already questions? Because I think it's important to start together from a basis that we really think, okay, everybody is there, understands where we are.
Yes, thank you, Prof. Arnt. So maybe from the participant, for those of you who wants to ask the question, please raise your hand or maybe drop your question into the chat box. Is there anyone?
No, seems not. So I hope everybody is with me and
Yes.
understands the story so far. So I'll just continue.
Yes, please.
So one of the questions that I had for you is about the effectiveness of all this pharmacotherapy stuff. And I think this study, it's an old study, but it's, to me, it's a very important one. And this Stefan Leucht, who has published this paper, his main work is publishing meta-analysis. So he does meta-analysis on antipsychotics, but also on other psychopharmaca. So he's very good in doing meta-analysis. And this meta-analysis, I show this picture to all my students every time, again and again. And I'll tell you why. So what you see here is, oops, sorry, well, this is one too fast. What you see here is on the y-axis, the effect size of medications. And then the interesting thing is there are white bullets and there are blue bullets. And this blue bullets does not represent necessarily a political preference, right? So even though the blue Biden seems to be ahead of the red Trump, this is just a coincidence that there are blue dots here. So don't worry. So here you can see the effect sizes of medication in physical conditions, general medicine. And you can see that there are some drugs that are really, really, really effective. For instance, paracetamol is very effective as a painkiller. For instance, some antibiotics are very effective in curing infections with certain bacteria. But on average, you can see that effect sizes are around 0.3, 0.5, which is okay. I mean, these are numbers needed to treat of maybe, yeah, what would you say, like 15, 20. That's a regular number to treat in general medicine. And what is also interesting, that we have quite some interventions, some medications that seem to be worse, so making the situation not better but worse, which is also interesting. But this is the average picture for general medicine. So the blue dots, what are those? Those are our psychiatric drugs. And if you ask a doctor or a student, usually, well, what do you think? Are psychiatric drugs, are they as effective as drugs in general medicine, or are they less effective or even more effective? And the usual answer that I get is that people say, well, psychiatry, I don't know, treatment of depression, it's not that effective. No. Psychosis is all, I don't think it really works. I mean, maybe a bit, but mostly it doesn't work. So it will be less effective than medication in general medicine. And what you can see here is that that is simply not true. So our psychiatric drugs are on average as effective as drugs in general medicine. And the effect sizes, well, they range mostly between something 0.3, 0.5, which is exactly the same as general medicine. Okay, we don't have this extremely effective drugs on our top list, but we also don't have this down there. So on average, it's roughly the same. So if we then take a closer look at the effect sizes of the drugs that are anti-craving drugs, so specifically for addiction psychiatry, think about naltrexone, acamprosate, disophorum, they are in the exact same range of effect sizes. So even medication for drug addiction, where people really think, well, I don't believe that it works, is simply untrue. Studies show that it's equally effective. And the interesting thing is that these students say, well, but it usually seems not to work in most patients. Well, they are right. Because, for example, naltrexone, if you have a number needed to treat of 10 or 11, that's what most studies with naltrexone show. That's quite a good effect size. If you compare it to all kinds of drugs from general medicine, having a number needed to treat of 10 or 11 or 12 is really, really good. But it means that you should treat at least 10 people to prevent one relapse. So it's true that in most people, this will not work. But that's medicine. In most people that we provide medicine, the medication doesn't work. That's what it is. And that's a pity, but that's what it is. And that equally applies to drugs in general medicine as in drugs in psychiatry or in addiction psychiatry. So, for example, if we provide people with antihypertensive drugs, or we provide people with, well, what you call it, cholesterol lowering medications. If you take the real endpoint, why we give it, you need to treat more than 100 people to prevent a cardiac event. Then a number needed to treat of 10 is quite good. So we should not withhold such good drugs as we have from our addicted patients. Of course, they still have to take it, right? So a key issue is getting this medication in these people, because you have to collaborate with them, try to motivate them using motivational interviewing techniques. But once you have this good therapeutic relationship, it's really important to make use of these kind of effective medications. So that's just a first introduction to evidence-based psychiatry, or evidence-based addiction psychiatry. And I think we can do better than this, honestly. I mean, yeah, we just discussed yesterday that, how can we personalize our treatments? These effect sizes that you see here are based on studies that are just RCTs. So everybody gets the same treatment randomly. And that does not take into consideration which treatment could work best for who. So I am convinced that if we do a better job than just randomly giving medication to our patients, but we really try to match the right intervention to the right person, that this number needed to treat of 10 can go down to a number needed to treat of 4 or 5. And we can use genetics for that. We can use our psychiatric examination for that. We can look at comorbidity, well, and so forth. That's not the topic of today, but that would be a next step. That would be a next step to further improve treatment effectiveness. And that's not something of the next century. That's something of the here and now. We can work on that.
Professor.
Yes, sure.
I wonder why the psychiatric drug is effective. Is that maybe because of the drugs, the psychiatric drugs is fit directly into the receptor, or maybe the pathophysiology of the brain disease?
Yeah, so I will show you in the upcoming slides how these drugs work. And you will see that it really taps into the pathophysiology of addiction. So it really comes close to what we talked about yesterday.
Okay.
So I think that's important. One thing that is always an issue in psychiatry, but it's also in in general medicine, is the placebo effect. That's a difficult issue because even for painkillers or for blood pressure treatment, we know that expectations about the effectiveness of a treatment contribute to its final effect. And it is thought that for depression, for example, the placebo effect might explain even up to 30% of the effect of the medication. So if you want to show effectiveness of your true medication over placebo, you have to do better than the 30% that the placebo already gives. So the effects that you see here, the effect sizes, are likely underestimations, because this is the difference of the true medication against placebo. But there is already the placebo effect that will also occur in our patients. So this is likely an underestimation of the effect size. So that is important, and we can make use of this placebo effect, among others, by explaining how these medications, how it works, and by explaining that there is evidence that shows that it works, and that will motivate patients, but it will also do something with their expectations. If you say, I have some medication, it's not very effective, but I don't really know how it works, but believe me, just try it. Then you do not make use of the placebo effect. So it's as a doctor, you can use the placebo effect to increase the chance that your patient will benefit from the medication that is in itself effective. But you can increase effectiveness by giving proper explanations. And sometimes you can also mention this. So sometimes I'm honest to my patients. I'm always honest to my patients, but sometimes I honestly share with them, like, your expectation is very important for the success of the intervention. If you start this intervention thinking it's not going to work, then the chances that it will work are lower. So then maybe we should work first on your thoughts about this treatment. Maybe we should first discuss how it works. I can give you some explanation if you want. And then sometimes I even take my computer and show them, okay, well, this is how the brain works. This is where it goes wrong in addiction. And this is with medication. I can do this to improve that. And then people start thinking, hey, this guy, he might be right. So this medication might be something for me because it might work. It might restore some things that are not going well in my mind. And then you make use of the placebo effect because people are expecting that your medication is going to work. And then the chance that it will work are, of course, also increased.
Yes, it's very insightful.
So it's not only prescribing a drug on a paper, but it's the whole story around it that is important. So maybe we should move on to these different medications. So this is a picture that I also showed you yesterday, right? So this is the reward pathway in a schema. So you have down here the high in the brainstem, the neurons that produce dopamine, they project to the reward part of the brain, so the nucleus accumbens or ventral striatum. And I told you yesterday that all the different drugs of abuse have their own entrance point in this reward circuit. So the stimulants are more at the synaptic cleft, where dopamine is released, and they prevent the reuptake of dopamine by the dopamine transporter. So dopamine is sort of taken back into the neuron by these dopamine transporters, and if you block that process, dopamine stays within the synaptic cleft, and that's why these stimulants are rewarding. Well, and all the other drugs have their own entrance point in this dopamine neuron. So this might seem complex, and you think, well, if it's that complex, what should we do? But you could also just turn it around and say, well, if this is true, then for each drug of abuse, we have an entrance point for our medication. Just another way of thinking about the same thing, the same picture. Because if there are all these different entrance points, there are receptors there that we can approach with medication. So why not make use of that? So I'll go through that step by step now. So alcohol, let's start with alcohol. That's, besides tobacco, I think the most common addictive disorder. So medication mainly targets at this reward system, as I said. So we have this medication here that's called modafinil, which is a cognitive enhancer, but I put a question mark there because it's still experimental. So I will not go into details of modafinil. Neuromodulation, the same thing, it's still experimental, so I put a question mark there. I'll not go into detail. Disophorum is interesting. I will discuss the mechanism, but the idea is that of course you become sick when you drink, because the acetaldehyde will increase, because the breakdown, the metabolism of alcohol is blocked by disophorum. So this mainly works because people think I should not really drink. So in a way, this helps people to activate their prefrontal cortex. Disophorum in itself does not prevent craving. Disophorum will make you realize that, oh, but if I take this, this will really be nasty and maybe even dangerous. So it's in a way a medication that tries to activate the prefrontal cortex because taking drugs will end up in a very bad situation. So it's not a direct effect then on the pathophysiology of addiction. So it's an indirect effect through the prefrontal cortex. But maybe we should focus on this row down here, because that seems to tap into this reward pathway, which is a central part of the pathophysiology of addiction. I'll go through them one by one, explaining the mechanism and why it could work. But for all these medication, all of them, there is evidence. There's good evidence that it works, and effect sizes range between 10 and 15. And it depends a bit on the study design. So which type of treatments patients are in the study. Are these outpatients? Are these inpatients? What is the primary outcome measure? So is it complete abstinence, or is it percentage abstinence days, or is it percentage of heavy drinking days? So you have all these different study designs, and depending on the study design, effectiveness might be a little bit higher or lower. But for all these medications that I will discuss with you, on average, they are effective and more effective than placebo. So these are in guidelines. So this is not experimental medication. This is all just guideline-based medication. So don't worry that these medications might not be as effective, even though we think we understand how they work. These are all effective medications that you could provide to your patients. So let's start with the first one. Naltrexone. What is naltrexone? Naltrexone is a mu opiate receptor blocker. So I showed you yesterday that alcohol has different entrance points in the brain. And one of the entrance points is the mu opiate receptor. So alcohol activates GABA, but also activates the mu opiate receptor. And by doing that, it stimulates the reward circuit. So it leads to dopamine release. And that's why we tend to drink again and again and again. And people with an addiction lose control over it, but that's a different story. So what could you think about doing? But if we block this mu opiate receptor, will alcohol still be rewarding? No. So if you take alcohol and it binds to the mu opiate receptor, then it induces dopamine release, then you feel fine. But if you put naltrexone there, alcohol comes around, it cannot bind. So what you can see here clearly in this picture, this is the normal situation. Alcohol binds to the mu opiate receptors, and then it leads to dopamine release further downwards in the neuronal cascade. So here you have naltrexone, which are the blue, again blue, I'm sorry for this blue all the time. So again, a blue bullets, the naltrexone binds to the mu opiate receptor. So when alcohol comes in, it cannot bind anymore, because these receptors are already occupied. So alcohol is not rewarding. And again, if you explain this to people, and then they experience it, because maybe they will try to drink alcohol anyway. So maybe one day they say, well, I want to try. And they don't feel the positive effect of alcohol. Yeah, then what's the use of drinking it? So I think you can provide this medication, but it's even more effective if you combine it with psychotherapy, explaining what you think that the effect of medication will be. That is the best way to go. But naltrexone simply blocks the euphoria that is caused by alcohol use. So on the right-hand side, you see that there are, of course, several opiate receptors, which is important because naltrexone, most studies suggest that it only blocks the mu opiate receptor, so it blocks the euphoria effects of alcohol. But there are also some studies that show that naltrexone might block the kappa opiate receptor. And the kappa opiate receptor is involved in dysphoria. So more, depressed mood kind of symptoms. And it might well be that by blocking this kappa receptor, people with comorbid mood symptoms also do better in their mood symptoms. So then the naltrexone might not only work for the alcohol use disorder, but also on the mood aspects. So I don't know whether you have naltrexone and nalmefene available in Indonesia, but nalmefene is a medication that works a bit like a naltrexone. It's on the next slide, so I'll share it with you. So nalmefene works on both the mu and the kappa receptor. So here you see again the same effect as naltrexone. There is the dopamine neuron, there is mu opiate receptors here, and what nalmefene does is blocking these mu opiate receptors. But nalmefene is quite known for its partial agonism on the kappa receptor. So for nalmefene, the claim is that by partially blocking this kappa receptor, it really takes away dysphoria. And what is very interesting about nalmefene is that you take it as needed. So naltrexone, you prescribe it and people take it every day in the same dose. And so it blocks these opiate receptors all the time. But nalmefene works completely in a different way because you only take it at a moment that you need it. So this requires patients to understand their addictive behavior. For example, in cognitive behavioral therapy, you could explore with your patient what are your risk situations? In what situations do you get craving? In what situations do you experience a risk to relapse? For example, a birthday of your mother-in-law. I can imagine that elicits some nasty feelings and you don't want to go there, but you have to. And then this stress increases craving and you want to drink. And the drink is available because it's a party. I'm just making up a story, right? If you know that that birthday will come next week, you can say, okay, well, that day I will start with taking my nalmefene. And I take it that day and the day after, and then you stop it again. And maybe there are other situations that you think are risky. Maybe if you have a meeting with somebody, or maybe if you have a period where you know, well, that conversation will really lead to stress, or but you have to understand how that works for yourself. And if you understand that, then you can, as a patient, know when to take the medication and when not. Some patients really prefer that because they don't want to take medication every day on a daily basis. They say, well, I don't need that medication every day. I know where are my risk situations. And only then I want to take medication. And for those patients, this might be a very good way to go. And it also gives them a sense of control. So they can control their medication use, they can control their addiction, and you help them with that process, which is also important from a psychological perspective. Is it a bit clear how naltrexone and nalmefene work?
Yes, Professor, maybe for the participants, if you want to ask question, please, or maybe
so yeah,
maybe
if there are questions, please ask them. You see that I'm not really into dosages because I think you can look them up yourselves, but I'm really convinced that understanding what you're doing is far more important than learning all the dosages, because these dosages you can look them up, but understanding how it works is a different story. So I think that's far more important for a lecture like this. Dosages are boring in a way, but you still have to provide the right dosage, of course, but it's a boring information, while understanding how it works is far more exciting. Okay, so then we move from the opiate receptor system to other medications for alcohol use disorders. And we move from naltrexone, which is the opiate system again, to acamprosate and disophorum. So acamprosate modulates the glutamate system. And you might know that alcohol affects, besides the opiate system, also the glutamate system and the GABA system. So it's not surprising that there's also medication that taps into the glutamate system or the GABA system. So acamprosate touches upon the glutamate system. And what it does, we do not fully understand, but we have the idea that it blocks the glutamate, one of the glutamate receptors. And by doing so, it blocks the activation elicited by craving. Because craving seems to work in part through glutamate activation that leads to dopamine release in the reward pathway. And if you block that process, then there is less dopamine release after cue exposure, and thus there is less craving. And when there's less craving, then there's a lower risk of relapse. And the studies so far have shown that naltrexone might be more effective in reducing the number of heavy drinking days, but not leading to full abstinence. And acamprosate might be more effective in reaching full abstinence. And there are even studies combining naltrexone and acamprosate, showing that it is more effective than taking one of those medications. And you can understand why, because it's a different mechanism. You tap into two mechanisms of alcohol use disorders, of alcohol addiction. So I wouldn't advise to provide every patient with alcohol addiction with two pills, with two medications. But if you have a patient who seems resistant to your treatment and keeps on relapsing, then why not combining two medications, as we do in depression treatment? You start off with an SSRI. If it doesn't work, you go to a tricyclic antidepressant. If that's not enough, you combine with lithium. You go with two medications. We should have the same stepped approach in treating addiction. You start off with the first medication, which is well tolerated by a patient, or maybe nalmefene, because the patient says, I don't want to take medication every day. Fine. If that doesn't work out, you move to naltrexone on a daily basis. If that doesn't work out, you add acamprosate. So you take a stepped care approach as you do in other conditions. Why not do the same thing in addiction? So that is a bit of how acamprosate works. And here in the upper panel, you can see Disophorum. So that, as I already told you, so it works on the metabolism of alcohol. So you have ethanol, which is degraded to acetaldehyde, which is further degraded to acetate. And Disophorum blocks this step, so this second metabolism step. So if you then take alcohol, it will be broken down into acetaldehyde, which is toxic. But this acetaldehyde will not be broken down into acetate. So this will increase. So you have more acetaldehyde, which is a toxic substance. And you will feel that. So it will provide flushing, it will increase blood pressure, heart rate. So that's not a nice thing to feel. And for people with cardiovascular conditions, it might even be quite dangerous. So please don't provide this medication to people with recent cardiovascular events, because that really might mean that they will not survive their next drink. Sorry for this interruption. I have a cat in the house and she wants to move out, so I have to open the door for my cat to move out. I'm sorry for that. What you see here is that Disophorum might work through this mechanism that people understand that, oh, if I drink, I will feel bad and it might even be dangerous, so I will not drink. But that's a cognitive process. What is interesting is that Disophorum has also been shown effective in some studies in cocaine-dependent patients. And that's strange, because cocaine is not degraded into acetaldehyde. So why would it work in cocaine dependence? So one thought is that cocaine maybe goes along with alcohol, and if people take Disophorum, they will not take the alcohol, and when they don't take the alcohol, they will also not take the cocaine. It could be. But if you look at patients on cocaine and with a cocaine addiction without alcohol addiction, they also improved on Disophorum, which is strange then. You cannot explain it by this mechanism. So they start thinking again about Disophorum, and what they found out is that Disophorum also not only blocks this enzyme, but also blocks dopamine beta hydroxylase. And dopamine beta hydroxylase breaks down dopamine. So if the metabolism of dopamine is blocked, then you have more dopamine in your brain. And as you can understand after yesterday's lecture, that might be a way of dealing with anhedonia and restoring dopamine activity in the brain, why people do not have the urge to take drugs. So that might be another mechanism of Disophorum out there that helps it being effective both in alcohol use disorders, but maybe also in other addictions. So yeah, that is just a sidestep. Usually people only think about this mechanism of action, but in fact there might be a second mechanism of action going on when you prescribe Disophorum to your patients. So maybe before we go to the next two medications for alcohol use disorders, is this clear so far?
Yes, there is one question, Prof. This is from Dr. Felicia Saraswati. She was wondering whether the drugs given for alcohol addiction are safe in patients which happen to have alcoholic liver disease, or are there specific choices for those patients?
Yeah, it's a good point. So I just talked about cardiovascular disease in connection with Disophorum. What is interesting is that Naltrexone is not that safe in patients with severe hepatic disease, so with hepatic failure or really damaged livers. Then there is an issue with Naltrexone. Acamprosate is rather safe. And the only issue in acamprosate is people with kidney failure. So you have to take those things into account. So it's important. It's an important question. It's an important remark that, of course, patients with alcohol use disorders are very likely to have physical complications of their alcohol use. And you always should be aware of that. Also in relation to prescribing medication and choosing the right medication. So I'm very happy that this remark was made. Otherwise, I might have forgotten to tell you about it. So thank you for that. Are there any other remarks or questions?
Professor Arnt and also Dr. Felicia Saraswati to ask this question. And the second question is from Dr. Florentina Reddy. She asks about in alcohol addiction therapy, when can we give these drugs? For example, naltrexone, disulfiram, etc. Is it only given when the patient is diagnosed with alcohol addiction? And is it effective in patients experience alcohol intoxication?
Yeah, okay, so that's also a very nice question. So when to start with this kind of treatments?
Yes.
And yeah, of course, first you have to have a diagnosis. So you will not start with medication before you have your diagnosis. I think that's obvious. I mean, that counts for every medication. You only start with medication if you have a diagnosis. The thing is that when people are continuously intoxicated, you can question whether you really have a working alliance. So you really have a good working relationship with your patient, and whether this patient will take the medication. Because if you are drunk all the time, yeah, the chance that people will take the medication as you prescribe it are, of course, smaller. So that would be reasons to first try other ways of either detoxify these patients, get them off the alcohol, or at least stabilize their alcohol use instead of being very, very drunk all the time. Just try to get it a little bit more controlled. But to be honest, that's not possible in all patients. And so it might be, you might consider treating people with medication, even though they might still use alcohol. It is important that it is safe to use this medication. So, for example, the things we discussed just before, in terms of kidney failure, liver, severe liver disease, or cardiovascular events. When people are intoxicated with alcohol, it might be hard to assess those physical conditions, and you have to make sure that it is safe that you prescribe these medications, of course. So that might be a reason to be a little bit reluctant, but yeah, if you really cannot get your patient into a more stable situation, you might consider giving this kind of medications. But I would not go for Disophorum, because that might become extremely dangerous when people continue drinking. You provide Disophorum, acetaldehyde will increase, and that is a dangerous situation. So except for Disophorum, the others are quite safe in combination with alcohol. But the best thing is that you try to get your patient in a working alliance and talk about stabilizing alcohol use, or even detoxifying them, and then from there start with your medication. And what I usually do is that I admit patients for a detoxification, for example, or we do the detoxification at home. And once they started their detoxification, then I also start with medication. It's a sort of trade. Like, I will give you something and you give me something. So if you give me that you really are going to reduce your drinking or you stop with it, I will help you with the medication. It's like a negotiation in a way. It doesn't sound kind maybe, but sometimes it helps to motivate people to take a step themselves, instead of, oh, give me the medication, and then they are not themselves in an active role of controlling their behavior. And I think the two should go together. It's not that, okay, you give me the medication, you cure me. In addictive disorders, it's very important that patients have the feeling that they themselves are also responsible to a certain extent. So I need them to be on board in trying to control their behavior. And it's not my medication that will cure them. We have to do that together. And if it comes from both sides, then you can say, okay, you cut down on your drinking, I will provide you with medication, and together we will get there. And then you are collaborating, and that usually is the most effective approach.
Yes, thank you, Professor.
Yeah.
Arnt. Yes, that's all.
That's all?
Yes.
Okay, so we move on to Topiramate and Baclofen. So Topiramate works on both GABA and glutamate, and we already discussed previously that alcohol works on GABA and glutamate. So what Topiramate does, it blocks the glutamate just like acamprosate does, but it also stimulates GABA a bit, and that's why it sort of might be especially effective in those with anxiety conditions, because anxiety runs through both glutamate and GABA. Anxiety is very comorbid in patients with alcohol use disorder. So if you have a patient with anxious symptoms, it might be wise to start first with topiramate. And what is also interesting about topiramate, given this profile, it's an anti-epileptic. So you know that people with alcohol use disorder may go into withdrawal seizures, and topiramate might protect them a bit from that. So this is another example of medication that you might consider early on in the treatment of addiction, of an alcohol addiction, because it might also protect against withdrawal seizures. And in fact, this medication is currently one of the most, maybe even the most effective treatments. The only thing is that the companies that make it start marketing it as an anti-epileptic, and they usually don't have that much of an interest in registering topiramate as an anti-craving drug. So in many countries, it is not registered as an anti-craving drug. So then you prescribe it off-label. But in terms of effect size and level of evidence, topiramate is at least as good as the other medications that are usually already registered for the treatment of alcohol use disorders. So even though it might not be registered in Indonesia for the indication of alcohol use disorder, I don't know, I didn't check. But I would feel safe prescribing it because the level of evidence is at least as good as for the other evidence-based medications for alcohol addiction. And especially in those people where you think of a risk of withdrawal seizure, or people with high in their anxiety, this might even be a first choice, even though it is an off-label medication. And that's a bit of a difficult issue, because if you follow guidelines, you should start with naltrexone, acamprosate, normophene, or disulfiram. And only when they don't work, you could move to topiramate because it's not a registered medication. But at the same time, we know that topiramate is at least as effective as the others. And in certain patients, maybe even preferable. So sometimes I don't follow the guidelines. I have to be honest here. Sometimes I take topiramate as a first or a second choice treatment in patients, even though it's not formally registered. And then I write down in the patient files that it is off-label, but I have my reasons to not follow the guidelines because of this and this and this argument. And I then usually say, there is good evidence in this review paper, so I choose to go for topiramate, even though it is not according to the guidelines. And I've never run into trouble with it, but yeah, you have to be aware of this. And then
maybe will become it's maybe will become an issue because maybe insurance will not assure the
we don't have that problem here in the Netherlands, but I could imagine you have that in Indonesia. That might be an issue. Sometimes patients will pay for it themselves, but that is also an issue. I mean, not especially patients with an addiction are not usually the patients with the highest incomes. Sometimes it is, but sometimes not. So that might be a difficulty with topiramate. I don't know about the universities, but they might play a role in trying to convince the government that topiramate should be registered for this indication of alcohol addiction, so that it becomes insured. And that is a responsibility that we also have as doctors, to convince policymakers based on science about the relevance of addiction as a disorder, that it should be part of the insurance, health insurance, and that there are treatments available that are effective and that should be covered by the health insurance. So
it's good to hear that.
Yeah. Yeah, sometimes it takes some time. I mean, we are now, I'm currently chair of the multidisciplinary guideline of alcohol use disorders in the Netherlands. And the previous guideline was from 2010. And so we are 10 years later now. And I will make sure that topiramate will come in that guideline. And then from there, you can go to the government and say, okay, well, now it's in the guideline. It has to be insured. It has to be covered by the insurance company. So you can, these things are not easy to arrange, but together we can get there. So, and Indonesia also has guidelines. So if you can work on the guidelines, we have to revise the guideline because there's new evidence. And then from there, slowly we will get there.
Yes.
So baclofen is a bit the same story. In some countries it's registered, but it's not. Baclofen is a GABA B agonist, which is interesting because we all know benzodiazepines who work on GABA A, but baclofen works on GABA B. And there has been this cardiologist in France, Armisen, who wrote a book about it. He was an alcohol addict, cardiologist, and he prescribed himself baclofen. And according to himself, that helped him. And after he started with baclofen, he never touched alcohol anymore. He wrote that story down in the book. And after that book came out, several studies were performed showing that baclofen is indeed effective across a different range of outcome measures. And 2 years ago, two meta-analyses appeared confirming that baclofen is truly an effective medication, but maybe not in all. So again, personalized medicine might be relevant because there are quite some studies, negative studies on baclofen, and there are quite some positive studies about baclofen. And if in a meta-analysis you look close to this, you see that baclofen in the end might be effective, but particularly in those with really heavy drinking. So taking more than 24 units a day, for example. So the real heavy drinkers are the ones that profit most, that benefit most from baclofen. And also here, there are some studies that suggest that those with anxiety might have the best response to baclofen. And that's probably, again, because it works on the GABA receptor. It increases GABA activity, through the GABA B receptors. The issue is that there have been also some reports that as benzodiazepines, baclofen might also be addictive itself. Even though it has a long half-life, it's not very addictive. But still, there are some reports of baclofen being addictive, and also if you stop it, that there might be withdrawal. So it is important, like the French, after this French cardiologist started with baclofen, they were the first country to prescribe baclofen on a large scale to alcohol addicts. And what happens in France is that they go up to extremely high dosages, maybe 100 to 200 milligrams. And what I usually use, and what you can also see in the literature, is that you don't need to go that high. You can, if you go to like 40 to 60 milligrams, is sufficient. So that is something to keep in mind, that people might develop some tolerance, and some people might ask for more and more and more, and that's not the way to go. So I usually go for 60 milligrams max, and then if it's effective, we can continue that but I usually don't increase to a higher dose because of this risk of physical dependence. Okay, so I think that's the list for alcohol. Given the time, because yeah, you already know from yesterday that I can talk for hours about this topic.
Yes.
So what I have is a similar
Sorry,
story
Professor.
of, yeah.
There is 45 minutes left.
45 minutes left.
Yeah, so it's time to discussions actually, but it's okay. Can continue the slide.
Yeah. So I have the same story for tobacco. There is medication there, so you can think about nicotine replacement, varenicline, bupropion, and Nontriptyline. Again, I have pictures of all the mechanisms, but that might take some time to talk that over. But yeah, I think also for tobacco use disorder, there are these effective medications that we can make use of. And I don't know the situation in Indonesia in detail, but as of 1st of November this year, so just a couple of days ago, we made our psychiatry department tobacco free. So nobody is allowed to smoke in the hospital or in the psychiatric departments. And we now convinced our government that as of 2025, all mental health facilities should be smoke-free, tobacco-free. So I think that's a very important development because tobacco is really a killer. I mean, people die. More people die of tobacco use than of car incidents, for example. So it's preventable, and there are treatments available for these patients. So we should not allow our patients to come into the hospital for treatment and at the same time kill themselves with using tobacco. It's really a strange situation. So that's why we decided to become tobacco free, and for that reason, yeah, it is important to help these people when they come to your facility and not say, well, if you smoke, you're not welcome. No, if you smoke, you're equally welcome, and we will help you with the smoking, and not only with the other conditions that you have, but also with the smoking issue. Because psychiatric patients are still the ones that smoke most, more than the general population. And psychiatric patients die on average 10 to 15 years earlier than the general population. And that's not because of suicide. That's because of physical complications, among others, from their high smoking status. So if we want to improve the life expectancy of psychiatric patients, here is a chance by helping them stop smoking. And we have medications available, psychotherapy available. So let's motivate our patients and help them stop smoking.
Wow, it's good to know that.
Yeah, it's important. And Indonesia is a country, in fact, where the smoking level is very high.
Yes.
I think in the Netherlands, we moved down now to about 20% of the population, which is still a lot. But I think in Indonesia, it's maybe 40% of the population or 50.
Yes, it's quite high.
Yeah. So and it's causing preventable death. It's a pity.
Yeah.
So,
but unfortunately, we don't have like Dr. Ilva said that nicotine replacement therapy.
You don't have it.
Yes, it's not available in this country.
Yeah, which is a pity because it's highly effective. So you have the cigarettes containing nicotine leading to a very quick high nicotine concentration in the plasma, which in turn stimulates dopamine release in the brain. So you have a rush of dopamine, which makes people take it again and again and again. So if you replace that quick rush of nicotine with medication that gives a more continuous level of nicotine in the blood, like chewing gum, nasal spray, or even better, a patch, then you sort of stabilize this nicotine dopamine system, and then people don't need to smoke anymore. And the best way to provide nicotine replacement is combining a transdermal patch with either gum or a nasal spray. So you have a stable level of nicotine in the blood, a stable level of dopamine activity because of that. And sometimes people have difficult moments in the day, for example, during a break or when they are stressed, and then they would like to smoke. But then you say, well, don't smoke, but at that time, take a chewing gum, a nicotine gum, or some nasal spray, and to help you through those difficult moments. So you combine a transdermal patch for the continuous level of nicotine in the blood with this as needed gum or nasal spray for the difficult moments in the day. And that gives the best outcomes if you combine both. If you do one of the two, the risk of relapse is higher. So varenicline, I don't know whether you have that available then, maybe also not. That's a partial agonist, which is an interesting concept. So if you smoke, the nicotine goes to the nicotine receptors, which lead to dopamine release in the nucleus accumbens. If you stop using nicotine, well, that leads to these receptors being untouched. So the dopamine levels will go down, which will make you feel anhedonic and, which will make you feel nasty. So you don't feel well. And the best solution then is to start smoking again to improve your feeling. But that is not going to help because that's the idea of the addiction. So smoking is really a difficult addiction to stop with. On average, people need about 6 to 10 quitting attempts before they are successful in stopping smoking. What nicotine replacement does is connecting to these nicotine receptors and then providing a sort of continuous level of dopamine in the accumbens. What varenicline does is an interesting concept. It binds to the nicotine receptors, providing some activation, but at the same time, it also blocks the nicotine receptors. So nicotine from tobacco cannot bind to the receptor anymore. So where nicotine replacement and nicotine through a cigarette is just the same substance, so they can go together. If you give varenicline, the drug blocks the receptor for the effects of nicotine. And in itself, it also provides some activity. So dopamine is not as low as going cold turkey, but taking extra nicotine by smoking will not work because these receptors, the nicotine receptors, are blocked. So varenicline is maybe, some studies show it might be even more effective than a nicotine replacement because of this mechanism. There have been some issues with safety, especially in psychiatric populations. Like several years ago, the idea was that varenicline might induce mania or psychosis, but the more recent studies show that this is not true. So it is safe in psychiatric populations, and the black box warnings were removed. So a couple of years ago, the FDA had a black box warning on varenicline for psychiatric populations, but that is not there anymore. But some people still think it's not safe, but that's simply untrue. So it's important to know that. Then we have 2 antidepressants for the treatment of tobacco use disorder. That's bupropion and nontriptyline. They work through the bupropion. Probably you know it. It's an antidepressant, blocks the dopamine transporter, and to a lesser extent also the noradrenaline receptor. So there is more dopamine in the synaptic cleft, and that's why it works. It works in depression to treat anhedonia, and it also works in nicotine use disorder. And the reason why it might be especially effective in tobacco use disorder is because it also blocks the nicotine receptor a bit. Not as much as varenicline does, but still a bit. So that might be a specific reason why bupropion is effective in tobacco use disorder. It blocks the dopamine transporter, it blocks the noradrenaline transporter, and it might also block, to a lesser extent, the nicotine receptor. Again, if you have a patient with a depression with severe anhedonia, it might be wise to take bupropion as your first choice treatment, because then you take both the nicotine use disorder as well as the mood disorder at the same time with one medication. So in those patients, you might consider not to start with the first choice nicotine replacement, but go directly for bupropion or even nortriptyline. So if you have a case with a severe depression, then you might go for nortriptyline directly because it's a tricyclic antidepressant, maybe more effective, probably more effective than bupropion in patients with severe depression. So a smoker with severe depression, I sometimes skip the SSRI and go directly for nortriptyline. And what does nortriptyline do? It blocks the noradrenaline transporter and the serotonin transporter. So nortriptyline increases serotonin and noradrenaline levels. So here you can see the nortriptyline molecule blocking the noradrenaline reuptake and the serotonin reuptake. And to a lesser extent, there are also indications that nortriptyline might block the dopamine reuptake, also increasing dopamine levels. So that's why it is both an antidepressant, also working on the serotonin system, but also for tobacco. So again, a plea for a personalized approach. Know that for the treatment of depression, the dosage of nortriptyline should be higher than for the treatment of smoking. So you might not follow, if you have a comorbid case, don't go only to the dosage recommended for the smoking treatment, because then you are under treating the depression. So you can just go for the right plasma levels, therapeutic drug monitoring for the treatment of depression. So you have the right blood levels of nortriptyline, and then you will also have the high enough dosage for the treatment of the tobacco use disorder. Okay.
Okay, Professor. So this maybe I will go back to the alcohol. There is a question from Dr. Levina Audrey.
Yeah.
I would like to know, maybe you can share any tips on history taking or starting to question for the patients about alcohol addiction without being obstructive.
Yeah. So I think this is very important. So if you have a patient with alcohol use disorder, you will have to be always very careful to bring up this topic. People might feel offended. As a GP, you usually, I think usually patients do not come with a question about their alcohol use. They usually come with a physical issue, like nausea or a stomach ache because of gastritis or pancreatitis or hepatic problems. They usually come with the physical consequences of their alcohol use. And what helps is, you do a history. So that is part of it. So, and sometimes it might need some explanation, that you say, okay, well, you have a stomach ache, and we know that several issues might contribute to that. So it could be about certain foods, it could be about smoking, it could be about alcohol use, it could be about drug use. So I just want to explore all these factors that might influence your physical condition. So let's start off with the food. That's the easy one. And then, okay, and do you also smoke? Oh yeah, you smoke. Okay, how many cigarettes a day? You just ask about it. And then, okay, well, same for drinking. Do you use any alcohol? And I understand in Indonesia this is more of a controversial topic because of the regulations, so the law. But still, I would just ask it and introduce it in a way like that. And the same for cannabis, the same for cocaine. Usually, if you as a professional feel embarrassed about it, your patient will notice and take over that embarrassment. If you as a doctor talk about it as if it is completely normal, without any prejudice or judgment, then your patient will feel more safe to be open about it. So I sometimes also even emphasize that you come to me with stomachache, I can only really help you if you are honest about these things. I will not judge you about it. I'm a doctor. I'm without judgment for you. I just want to help you. And in order to be able to help you, I just need to know. I really need to know, what kind of food do you take? What do you smoke? Do you drink? Do you take drugs? I really have to know, and I will not tell it to anybody. That's my that's my oath. And I have no judgment. I will help you if you take drugs or not. It's fine with me. But I really need to know. Otherwise, I cannot help you. And that might help stimulate people to be open about it. It's the same as talking about sex. I mean, sometimes doctors are sort of embarrassed to ask about people's sex life, but we also should do that when it's needed, because that might be there might be problems there. So if there is an indication to talk about it, you should just talk about it as if it's a normal thing to talk about. And for drugs, it's the same thing. For alcohol, it's the same thing. The most important thing is that a patient really feels that you're not going to judge him or her. As soon as there is a bit of judgment there, that will prevent people from being open.
Okay, thank you, Prof. Arnt. It's very nice answer. And Dr. Levina also asked if you have any recommendations or for further reading or videos for interviewing tips.
Yeah, so what I would really recommend, because next a colleague of mine, a psychologist, will provide a lecture on cognitive behavioral therapy. Yes. So there will be more on cognitive behavioral therapy in one of the upcoming lectures. Motivational interviewing is a basic communication skill. And that you can use it for anything, but also for interviews with people with addiction. But you can also use it for convincing people to take their medication for physical conditions or whatsoever. So if I show you a bit about motivational interviewing, then you can look at videos, motivational interviewing. There are all kinds of examples on the internet. Many, many, many examples on motivational interviewing. And especially the videos by Miller and videos by Rolnick are very instructive. I can even share some links if you want later on. But what you primarily do in motivational interviewing is that you assess whether a patient is ready to take action or not. Because usually as a doctor, you think, okay, there is a problem. let's start with the action, take medication, change your behavior, and then it will be better. But we are far too fast usually. So people sometimes they are not aware that there is a problem. So you will not change your behavior if you're not aware that there is a problem. So the first task in your consultation is to help people understand that there might be a problem and bring them from pre-contemplation into contemplation. So they start thinking about it. That might be a goal of one consultation, to get people think about it without any action. Then, if you have people think about it, a next goal could be to have them prepare themselves for some change. Well, if that is really true that this stomach ache relates to my alcohol, if you are right about that, yeah, then that might be a reason to reduce my drinking a bit. And you can continue on that without taking action. You prepare somebody. How? Well, if you would consider cutting down on your drinking, what could help you with that? Could I help you with that? Could your wife help you with that? Are there other things? Why do you drink? Do you drink because of stress? Maybe we should think about other ways of coping with stress. Or are you depressed? We could think of ways to treat your depression and help you. And once you have done that, only then you can prepare for action and really behavioral change and medication. And once you have had this action, it's not ready. Next step is to discuss, well, now we have changed some things. How are we going to think about preventing relapse? Because changing behavior is not easy. I don't know who of you have ever tried to reduce weight and increase sporting activities. It is not easy to change your behavior. And once you have changed it, it's not easy to maintain it. There's a high risk of relapse going to fat food and reduce on sporting again. We all know that. And for addicts, it's even more difficult. So to remain abstinent or prevent relapse. So we should not stop helping our patients directly after the first change has occurred. And we should even prepare ourselves that once in your life, the risk that you relapse is really there. And what are you going to do then? I will still be there for you. It's not that when you relapse, I don't want to see you anymore. That's the moment that I really want to see you to be able to help you. And we can anticipate that this will occur, because in addictive disorders, it is very likely that this relapse occurs. So when this occurs, who are you going to talk to? Are you going to talk to me? Is your wife going to talk to me? How can we prepare ourselves for relapse that it will not end with severe complications, but as soon as the relapse is there, that as soon as possible, we start working together again to get control back again. And there are simple conversational techniques to go through these different stages of change. These are just a simple thing, but the most important is that you don't judge your patient, that you listen well to your patient. So the part down here, you ask open-ended questions, you summarize what you hear in your patient, and you try to encourage change talk, because change talk is the effective ingredient of motivational interviewing. The more change talk you can get with your patient, and that is like, I can do it, or I really want this to change, I'm convinced that I'm going to make it happen, it's so important, it must change. Those kind of words is all change talk. And the more change talk you can get in your conversation, which is just a technical issue, how you ask your patients your questions, you will increase change talk, and that will predict the chance of behavioral change in your patient. So look at those videos and see how you can encourage change talk, because that is the most active ingredient of your conversation to be successful.
Right, thank you, Prof. Arnt. And this is also a question from Dr. Desi and also Dr. Florentina Reddy. that asks about how to help our patient with nicotine addiction without oral treatment or nicotine replacement therapy.
So, how to help without medication?
Yes.
So that is basically this. So we have a different psychosocial interventions, and motivational interviewing is the easiest one, I think. Easy to learn and very effective. Cognitive behavioral therapy is another approach, is highly effective across all the addictions, including smoking. And my colleague will explain about that in another session. And then you have more specialized treatments. So you have community reinforcement approach, self-help groups, 12 steps models, and also internet treatment. I don't know what you have available in Indonesia concerning internet treatment, but those are usually more specialized. But motivational interviewing, I think every doctor should be able to do that to a certain extent. And cognitive behavioral therapy also includes some not too difficult interventions that can be effective and are not that specialized. So this could be a good approach. And I know that you also have psychologists with private practices there in Indonesia. Psychologists are usually very well able to perform cognitive behavioral therapy. So if you talk with your patient in a motivational way and you can motivate your patient for a consultation with a psychologist, I mean, that is wonderful.
Thank you, Professor. So the other question is, when is nicotine replacement said to be no longer effective and need to be replaced by bupropion? Is there a certain time when the maximum nicotine replacement is carried out? Or are there other reasons such as socioeconomic factors?
Well, this is a very interesting question, and in fact, it's difficult to answer because there is not much evidence there. I told you that I'm the chair of the committee revising our Dutch guidelines on alcohol use disorders, and we have exactly the same issue there. There are hardly any studies showing how long you should try one treatment before you move to the next. In mood disorders, we usually say, well, you wait 4 to 6 weeks and then you look at the effect. And if it's not effective at all, then you can switch your treatment. But for addictive behaviors, we do not really have those studies. We do not really have that evidence. So from a practical point of view, I mean, it will not work within 1 or 2 weeks. So you have to give it some time. Behavioral change is not going to happen within a couple of weeks. That takes time. So usually when I treat people with this medication, I will combine it with a psychological intervention. And then you are usually on the way for at least 2 or 3 months. So usually by the end of that time, 2 to 3 months, I start the evaluation on effectiveness. And if a patient then says it doesn't help at all, then that might be a good moment to switch. Of course, if people have adverse effects earlier on, that might also be a reason to switch earlier. But the effectiveness, I usually take my time, like 2 to 3 months to evaluate that. But there are no strict guidelines there. We don't have strict evidence there.
Okay. Thank you, Professor Arnt. So that's all the questions from the participants. Maybe I would like to ask a little bit tricky questions.
Mm-hmm.
So what is the position of the imprisonment penalty for addictive treatment retention?
Yeah, that's a political question. So, yeah.
also included from the community reinforcement?
No, so the community reinforcement approach is an approach where you try to seek the rewarding aspects of a drug-free life. So you look for healthy things in the life of your patients in the past. And I always give the example, I have 2 kids, 2 sons, and I love to go to the cinema with them. Now it's not possible because of Corona, but it's something that we really like to do. And sometimes, if an addict is really struck by his addiction, then these nice things in life go to the background. And if you can identify these kinds of important things for an individual, what you can then do is provide priority to those healthy activities and explore whether a patient can make that happen again. So sometimes it is needed to restore the contact between the patient and the family. Sometimes it is needed to work on getting a job or those kind of things, but help a patient to get back to activities that are healthy without drugs. And we even sometimes provide vouchers to patients to be able to do that. So for example, you can check cocaine use in urine, and you say, well, if you have 1 week of urine sampling without any cocaine, you get a €10 voucher. And with that €10 voucher, you can only spend it at the cinema with your kid. So you prepare in your therapy how this patient will do that cinema thing, how he will deal with his kid. Maybe the kid has questions about the alcohol use, but so you prepare that cinema visit very well together. And then if the patient becomes motivated for that, he or she will provide in the urine samples without cocaine, so you provide the voucher. And then after that cinema visit, you evaluate. And from there you increase the number of healthy activities. So it's like a reward. You take the reward system back from the drugs to more healthy behaviors, using these vouchers, for example. And I think that's a very, very effective approach. And it's not punitive at all. Punishment is not going to work. We know that these people have a low punishment sensitivity on average. Punishment is not going to induce behavioral change. What punishment will do is make these people feel worse about themselves. They feel more ashamed. They feel that they don't behave the way they should be. And that only adds to, like what we saw yesterday, it only adds to the pathophysiology of addiction. So with punishment, you're not going to help them, but you're only making it worse. So the other approach, motivational interviewing, community reinforcement approach, looking for reinforcing activities and try to get this reward system back from the drugs into a healthy lifestyle. That's the way to go. Punishment is not effective.
Well, thank you, Professor. So I would like to invite for the participants who want to ask question, maybe only one question, because we have maybe 5 minutes left until this session will end. Anyone? And also, maybe I would like to ask about what are the, how can you control the patient so that he does not get addicted to our prescription drugs?
Yeah, that's also a nice question. Note that all the drugs that I discussed today, maybe except from baclofen, are not addictive. So the medications that I discussed today is not that much of a problem. For example, methylphenidate is a different story. So methylphenidate is addictive in itself. That is something to consider. So what helps is to be aware of that, to discuss that with your patient, and to follow up on it. And if you really think that this might be a risk, then you can always think about long-acting agents. So not prescribing short-acting methylphenidate, but long-acting methylphenidate, because that's less addictive. And there are certain signals in your patient that they are not using the medication as you prescribed it. For example, when the prescriptions are ended and they need additional prescriptions, well, then they must have used the medication. And then you get all kinds of stories like, oh, I flushed it through the toilet, I lost it on the way. Well, that can happen one time, but if that happens again and again and again, yeah, you should consider that this person might misuse your medication, and you don't want to be a dealer. You want to be a doctor. It also helps to make sure that you have a good working alliance with your patient. If you have regular visits and your patient comes regularly, that also can be reassuring for you that the patient is taking the medication as you prescribe it. And that's not needed for every patient. So most patients will not misuse your medication. And you can think of which patients are at risk based on family history, based on prior history of substance use disorders. And then you should avoid not treating them well. So it's important to provide them with a good treatment, but maybe supervise it a little bit more closely, so that you make more regular visits with your patient, or that you ask family around the patient to also keep an eye on it a bit. So you collaborate with the patient and the direct environment of that patient. Always open, that's how we work. I mean, I'm open about these kind of issues to my patient and the husband or wife or mother or father or whatever. And sometimes sometimes it goes wrong. I mean, that's part of life. You cannot always prevent these things from happening.
Thank you, Prof, for the nice answer. And maybe all of the questions has been answered. And also, yes, this is the end of our session. Thank you very much, Professor Arnt, for your broad knowledge give to us.
Yeah, well, I hope that people enjoyed it.
Yes. I can hear your lecture maybe for about 4 hours.
Yeah, I can talk about 4 hours, but that's too long. Tomorrow we have another day. We have another lecture, and then it will be on opiates and chronic pain. So that is also a very exciting topic.
Yes, thank you very much. Maybe I will try to summarize a little bit from this interesting session. So from your lecture, we got that addiction is a complex illness. There is no single therapy is appropriate to everyone. And also effective treatment attends to multiple needs of the individual, from psychological, physiological, and then environment. And also we have to consider about the comorbidity of the patients, they tend to have other mental disorder or vice versa. And then relapse is also does exist. So we have to maintaining the treatment for an adequate period of time is important. And also the best way to treat patient with addiction is personalized. So both medication and behavioral therapy is at the same time, all coming together to reach the goal that the patient will return to productive functioning in this family. All right, that's all for today. Thank you, Professor Arnt. Terima kasih.
Sama-sama. Terima kasih. Sampai
Jumpa besok.
Ya, besok ya.
I will turn the mic to the host, Dr. Evelyn.
Okay, thank you, Dr. Duratul Ikrimah and Prof. Arnt. Finally, we come to the end of this event. Thank you very much for your participation in this session. Hope you enjoyed the program, and here's some last information for you. So the post-test link will be copied to the chat room, and we will wait 2 to 3 minutes for you to click the post-test link before this program ends. And then I will remind you that e-certificates are only given to participants who has filled the registration and pre-test before each session, and also post-test with pass limit value 80, and it can be repeated if you haven't reached the pass limit value. And the post-test will be closed at midnight, 12 a.m. West Indonesian time on each day. And for next seminar session, don't forget to join our seminar session tomorrow on 6th November 2020 on this, at the same time, 1:20 p.m. And you can register. The link will be copied on the chat room. And don't forget to follow our Instagram, Addiction Talks ID, for further information. Once again, thank you, Prof. Arnt, psychiatrist, colleagues for attending this lecture. I suggest for all the participants to turn on the camera so we can take our photo together before we end this video meeting for documentation. Okay, yeah, maybe a smile. Okay, thank you, Prof. Arnt.
Bye-bye. See you tomorrow.
Bye.
Tomorrow.
Ciao.
Thank you. Bye.